I just want to see their reaction. Seated. Notice anything? I need to thank Paul and Susan. The PFM was giving us problems, and mysteriously they all disappeared this morning. I don't understand. But let's see how it works, okay? We're going to continue on with the testimony. Oh, one other thing. I've had a scratchy throat all week. I tested this morning. I'm negative. So if you see me up here eating cough drops, it's a little scratchier this morning. So, but I just want to let you know I'm safe, I think. With the weather change, another cold. Okay, we ready to proceed, Ms. Sawyer?
We are, Your Honor.
Call your next witness.
State would call Troy Rudman to the stand.
Y'all have a good evening? I'm waiting for this weather to come. Thank God we're off Friday because that's supposed to start hitting Friday.
Yeah.
Okay, sir. I need you to raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
Yes, Your Honor.
Okay, once again, make yourself comfortable. You have an aerial mic there in front of us. If you wish to lower your mask, you may. Okay? I need you to state your name and then spell your name so this young lady can get used to your diction. Okay? Go ahead.
My name's Troy Rudman. Spelling is Troy. Last name Rudman.
You guys hear him? You want some volume? Yeah. I know you got a little bit more in you. Okay?
It's early.
Give us a little more volume. Ms. Sawyer.
Thank you, Your Honor. Mr. Rudman, let's start with your background. Where did you go to college?
Yes.
And where did you go to college?
Mount Carmel College of Nursing.
Okay, and what degree did you get?
Nursing degree.
When did you receive that, Mr. Rudman?
In 2014.
All right, I'm going to ask you to speak up a little bit, okay, because I'm having a little bit of trouble hearing.
In 2014.
Okay. After that, what did you do after you received your nursing degree?
I took the boards for nursing and then got my license in July of 2014.
Did you work as a nurse after that?
Yes, at Mount Carmel West.
Okay. When did you become employed at Mount Carmel West, sir?
In August of 2014.
And how long did you work at Mount Carmel West?
Until July of 2019.
And what happened there, Mr. Rudman?
I was terminated.
At some point, because of your employment at Mount Carmel West and what happened, did you have to go before the nursing board?
Yes.
And tell us what happened with that.
It was a state...
I would just note an ongoing objection. Thank you.
Okay, I overruled.
Go ahead, sir.
It was a stayed suspension, so I still have my license.
Okay. And are you currently employed?
I am.
In a medical field or a non-medical field?
Non-medical field.
All right. Let's talk a little bit about when you first started working at Mount Carmel West. What were you doing at that time, sir?
I was hired on as a staff ICU nurse in the neurological ICU.
And how long did you work in that position?
About 6 months, and then our departments were merged into the entire ICU, so medical, surgical, cardiac, and neurological.
Okay. And what did you do at that point when they merged?
Staff ICU nurse.
How long did you hold that position?
Until January 1st of 2017, when I became a rapid response nurse.
Tell us what a rapid response nurse is.
Bring the volume up a little bit there.
In 2017, I became a rapid response nurse. That's a nurse that is tasked with going to every floor and trying to prevent ICU rebounds, so people that were transferred out of the ICU so that they didn't come back to the ICU, and also responded to code situations, emergent situations, and facilitated transfers from the step-down or the normal floors to the ICU.
Now, when you responded to emergency situations, what was your role in regards to that as a rapid response nurse?
So my role, I would show up. Anyone in the hospital had my direct line. They could call me. I would show up, analyze the situation, speak with the nurse assigned to the patient, and then basically do whatever was needed for that patient in that given time.
So you were all hands on deck?
Yes.
Okay. How long did you hold that position, Mr. Rudman?
Until December of 2018.
And what happened at that point?
I was put on administrative leave.
And how long were you on administrative leave?
Until July of the following year, 2019.
Which was when you were terminated.
Correct.
As a neurological ICU nurse, what were your job duties for that?
In the neurological ICU, we would deal with traumatic brain injuries, strokes, primarily patients that had any brain injuries or any acute traumas to the head or brain.
And you said you would deal with them. What were your specific jobs in regards to those patients?
As a neurological nurse?
Correct.
To monitor, to assess, to carry out orders given to me by a physician.
When you switched to just a straight ICU nurse, what were your job duties at that point?
The same role.
And at this point, what type of patients are you caring for?
Any patient, really. Any surgical, cardiac, neurological, general medical. It was an entire ICU that was a mixed ICU.
I would say for the years you worked at Mount Carmel West ICU, you became very familiar with the ICU unit. Would that be accurate?
Yes.
When you first started, what type of orientation or training did you receive coming straight from nursing school and your board and going straight into working?
So we were paired with an orientee, which was a tenured nurse on the unit.
Okay.
We followed them around and helped them in their day-to-day, so learned on the job for about 10 weeks, and then we took our own patients after that.
Okay. Was there any type of ongoing training at that point?
There were some health stream modules, which was the hospital's education department, and much past that, it was mostly on-the-job training.
And once you received your nursing license up until today's date, is it still in a valid nursing license?
Yes.
And you maintained all the continuing education courses you needed to do so in order to maintain that?
Yes.
Mr. Rudman, I'm going to direct your attention, and this has been marked as 15BB. Can you identify that for us?
That's Mount Carmel West.
Okay. And I'm going to show you what's been identified and marked for identification as State's Exhibit 15B. Do you recognize that?
I believe that's the family room we use for loved ones going through difficult situations, and it would be a place where the physicians could speak to them directly in a quiet, controlled environment.
And that's at Mount Carmel West?
Yes.
In the ICU area?
Yes.
Okay. And what's been marked for identification as State's Exhibit 15C, can you identify that for us?
I'm not sure.
Okay.
This might be the same room, but I'm not sure.
If I can show you. All right, certainly looks like it.
Yeah.
Would you agree? And 15D appears to be another angle of that same room.
Yes.
And then what I've marked for identification as 15E, do you recognize that?
Yes, there's the Pyxis machine in the back of the ICU.
All right, and that would be this area?
Correct.
15F?
The same.
Okay. Pyxis machine again?
Correct.
15G?
Another view of the same Pyxis machine.
15H?
Another view of the Pyxis machine.
15I?
Another view of the Pyxis machine.
And 15J?
The Pyxis machine.
All right, now tell us a little bit, what is the Pyxis machine? What type of, does that mean to you?
The Pyxis machine was used to get medications for our patients. It held any medication that we needed or used in the ICU. For the most part, we would scan our badge, use our fingerprint, and have a login, dedicated login for access to the Pyxis machine.
All right, so if you withdrew medication from that, did it create an electronic record?
To my knowledge, yes.
And it would show, because it's a login and your fingerprint, thumbprints used, it would show it was you?
Correct.
Can you identify 15K for us?
It's a room in the ICU.
And 15L?
The same room in the ICU, room 9.
15M?
Another view of the ICU room.
15N?
The ICU room with the patient's bed.
15O?
This is the back of the patient's room that shows the monitor.
Okay, and explain to us what the monitor and this whole area is for us.
The monitor was used to continuously monitor the patient, whether that be blood pressure, heart rate, oxygenation. There was also access to oxygen and suction on that same pillar next to the monitor itself.
Okay. And was that common for all of the ICU rooms at Mount Carmel West?
Yes.
15P.
That is the back of the room, which showed the sink and toilet that we could access.
15Q.
Sitting area in the patient room.
15R.
Another seating area in the ICU room.
15S.
The bed and the computer monitor that we would use.
How is this monitor different from the other one we talked about?
The computer monitor we would use to chart, to scan in medications. Really any aspect of our assessment was charted and utilized through that computer.
Okay. Now, you just said you scan in medication. So once you withdraw the medication from the Pyxis machine, what do you do from there?
So from the Pyxis machine, enter the room, obviously, log into the computer. We would scan the patient's ID band.
Okay.
We would also ensure that the order was under the correct patient at the correct time. And then we would scan in the medication itself under the certain time that it was due in the medical administration record.
So I'm assuming there's a bar on the medication vial itself?
Yes.
And is that the scanner area I'm looking at there?
That's correct.
Okay. And I probably should have switched the picture to 15T because that shows us a close-up. Same monitor?
Yes.
And close-up of what we just talked about.
Yes.
And 15U, again, same thing?
Yes.
15B, what is this?
That is the front nurse's station, and it has the front Pyxis machine to the right.
Okay. Explain to us why this is the front. Is there a back area also?
Yes, the first pictures were the back area of the ICU. It was a large unit, so
Okay.
there was multiple Pyxis machines throughout the different units because of the number of beds.
Do you know how many beds there were in the ICU at Mount Carmel
I don't
West?
remember the exact number.
Okay. And the back area you said we saw first, so this is the front area.
Correct.
Do you remember how many Pyxis machines were at the Mount Carmel ICU?
The main ICU, there were two.
Okay.
There was also a Pyxis machine in the CV ICU, or the cardiovascular ICU,
Okay.
which was next door. And then we also had a step-down ICU that had its own Pyxis machine.
Now, we've heard some talk that the ICU may have been on multiple floors.
Correct.
How many floors, sir?
When the neurological ICU was in existence, there was technically 2 floors, but they were split by multiple units.
Okay.
So there were, or 3 floors, I should say, with the step-down ICU. There were, the main floor held the medical ICU and the cardiovascular ICU.
Okay.
And then there was a separate floor for the step-down ICU, and the neurological ICU was across the hospital on a separate floor.
All right. Now, that's the first time we've ever heard anything about a step-down ICU. Can you explain what that is to us?
The step-down ICU was brought into being because we needed some overflow at times, and then also when there was a lack of beds in the hospital, and some patients were potentially too sick to be in a normal hospital floor, but not sick enough to warrant an ICU bed, we would have a step-down ICU that would help with that overflow, and that would be staffed by ICU nurses.
Okay. All right. 15X. What is that?
That is the front Pyxis machine.
Okay. 15Y.
Another view of the front Pyxis machine.
All right. Now, if you are withdrawing medication from the Pyxis machine, where do you go to enter your thumbprint and your ID code?
At the main monitor on the left, to the right, there's a small circle that would be used for our fingerprint.
Okay.
Hold on, you have a pointer.
Yeah, I was going to say, I think there's a laser pointer up there.
Would that help you?
Can you see if you can
Yeah.
point that out to us?
So this would be the fingerprint sensor on the Pyxis machine.
Okay.
This would be the main screen that we would use to input the information, and then the keyboard right
Okay.
here.
And where do you obtain the medication from then?
Depending on what medication, there was a fridge that held refrigerated items.
Okay.
There were drawers in this unit. There were also drawers in this unit, another fridge that had overflow, and then they called it a refrigerated section, but this was just a shelving system that held other medications as well.
So if you enter your thumbprint and your ID, does the drawer pop open, or do you have to actually physically open it?
So you would have to choose the patient
Okay.
that you were accessing medications for.
Okay.
Dependent on the medications that you chose, the various drawers would open after you hit accept that you were withdrawing those medications.
Okay. All right, so going on with the remainder of this, 15Z, what does that show?
This is the middle section of the unit. Behind this photo would be the Pyxis machine that we just looked at.
Okay. And 15AA, what is that?
This would be around the emergency department entrance of the Mount Carmel West Hospital.
All right. Mr. Rudman, those photographs that I just showed you, States Exhibit 15B through 15BB, do those show the hospital in the same or similar condition as when you worked there?
Yes.
True and accurate copy of what you saw in those working days?
Yes.
So let's continue talking a little bit about the Pyxis machine, Mr. Rudman. So who enters the actual order for the medication?
So the physician can enter the order through the computer. We can also take verbal orders and enter the order through the computer as well.
So if you take a verbal order as the nurse, which computer do you enter that medication order at?
Any computer in the unit can be used to do that.
Including the one on the Pyxis machine?
No.
Okay.
So that's specific to the Pyxis. The computer in the room or at the nurses' stations could be used to chart and enter orders. The Pyxis machine was a dedicated piece of equipment.
All right. So if you would get a verbal order, when would you typically, as the nurse, enter that order into the computer? Before you withdraw the medication, after the medication, somewhere else?
It depended on the situation.
Okay,
If it
explain
was-
that to us, please.
If it was an emergent situation, we would withdraw the medication, take care of the patient, and then enter the order after the medication was given.
Okay, and if it's in a non-emergent situation?
Usually the physician would enter that order as a scheduled order, and it would be in the computer put in by whatever physician that ordered it.
How would you be alerted to one that the doctor would enter?
It would show up as a timed administration or as a PRN or as needed medication in our MAR or medical administration record.
All right, so explain to me what as needed means to you as the nurse.
So as needed was oftentimes used for pain medications. If the patient was in pain, we would sometimes have standing orders for Tylenol or various medications for pain, or even if a patient had a fever, we would have PRN orders or standing orders that we could use as needed.
Okay. And in those situations, does that mean you don't have to wait for a new order from the doctor?
Correct.
We've also heard a lot about obtaining medication via an override in the Pyxis. Does that mean anything to you?
Yes, it was very common in the Mount Carmel Health System for overrides.
Okay, so explain what you mean by override when you say it.
An override would be any time that you would override the Pyxis to withdraw medication for any given patient. If you didn't have an order, or for some instances, there were also pieces of equipment or sterile water, saline that were in the large sections of the Pyxis that wouldn't necessarily have an order, but we would have to override to access that.
And when you're referring to override, does that mean anybody else is reviewing that prior to you pulling it?
Prior to?
Correct.
Not always.
Okay.
If it were in an emergent situation and we pulled the medication, it would potentially be reviewed after we had given the medication.
And reviewed by who, sir?
Pharmacist and the physician.
So what is your understanding that of what the pharmacy does when you pull medication from a Pyxis machine on override?
My understanding of their job, I don't really know their exact
That's fair.
protocols associated with that.
Okay. What if you wait for their approval? Tell us how that happens.
Within a medical administration record, when an order is placed by a physician or by a nurse, the pharmacist will electronically review the medication, such as an antibiotic. They might check for allergies or that the dosages are appropriate for the patient, and they could approve or deny the order.
Okay. How do you get notified of whether it's approved or denied?
Within the MAR, medical administration record, it would show as an approved by the specific pharmacist that did that or denied.
So tell us what you're doing as if you're entering a medication and then waiting for pharmacy. Where are you at and what are you looking at?
Depending on how busy we were. If it were a non-emergent medication, we might be attending another patient, assisting with another nurse, or potentially charting at that time.
Okay. And then how do you know it's been approved or denied?
We would have to check the MAR
Okay.
to verify that.
So you'd have to physically go into that patient's record, look at the MAR to know it.
Correct.
Did you ever have a situation where the pharmacist would call you about a medication order?
They could. I don't remember any specific time for myself as a nurse.
You talked about obtaining via an override, medication via an override in an emergency situation. What was your understanding of what an emergency situation would be?
An emergency situation would really be any situation where the waiting for any period of time could potentially harm the patient in any way.
Was there a crash cart that was available for any code blue?
There were several crash carts on every unit in the hospital.
Explain to us what would be on the crash cart.
Crash cart would hold a monitor, defibrillator, also medications that would be used in code situations or emergent situations, including saline bags, suction equipment, really anything pertaining to a code blue situation.
Would there be any medication on that crash cart?
Yes.
What kind of medication would be on that crash cart?
Medications such as amiodarone, epinephrine, really any medication that would be used in a code blue situation, and then the pharmacist would have access to that to help mix any solutions that were needed, such as Levofed or other drip medications such as those.
Okay, so those medications you talked about, Levofed, what is that used for?
Levofed was used as a medication when a patient were in shock, blood pressure was dropping. The vessels would constrict down, which would increase the blood pressure for the patient.
Is that what we have heard called a vasopressor?
Yes.
Okay. The epinephrine.
Hold on. You mentioned 3 drugs. Can you spell them? This isn't a test, okay? But this poor young lady's taking it down, so I was just getting the spellings for it.
We'll start with Levofed, Levophed. and amiodarone, AMIOORADONE, I believe.
It's okay, this isn't a test.
And then, what was the third medication?
Epinephrine.
Epinephrine. EPHIPHERINE.
She types phonetically, so helping her with the spelling is something I
Sure.
try to do. And I'm sorry for
No,
interrupting you.
that's perfectly fine, Your Honor.
I just want to keep her happy.
So what's epinephrine used for in a code blue situation?
Epinephrine is basically adrenaline, so it can be used to help jumpstart the heart when cardiac arrest occurs.
Okay, and the other one,
Amiodarone
That one.
is an antiarrhythmic,
Okay.
so it can be used when the heart is beating, but in various erratic heartbeats. It can be used to correct that into a normal, what's called a sinus rhythm or a normal heart rate.
Okay. Mr. Rudman, you've had some involvement in your role as a nurse with some of our victims in this case. So I'm going to direct your attention first to, and I'm going to start on this pen, to what I've labeled as 14G. Can you identify which patient this is regarding, sir?
Melissa Pennings,
And her admit date was what date, sir?
11/15/2018,
And discharge date?
11/20/2018.
Okay. And I'm only going to direct your attention to your involvement with Ms. Pennings. So, and is that big enough for everybody to see? Okay. So in the middle of the page here, is that your name at the bottom?
Yes,
And what date were you involved with Ms. Pennings on?
11/18/2018.
And what was your involvement at this time? And I don't think I asked you, did you work a specific shift during your time at Mount Carmel West?
Yes, night shift,
And what hours were those, sir?
7 p.m. to 7 a.m.
And when you were specifically in the ICU, were there specific doctors you worked with?
In the ICU or as rapid response?
First as the ICU.
ICU, it depended on what service was on for the given patient.
Okay.
For the general ICU, it was either Dr. Husel or Dr. Hagras most nights.
Okay. So when you were in the rapid response team, you responded to the entire hospital?
Yes, ma'am.
So I'm not even going to ask how many doctors you interacted with.
Probably can't count that high.
Okay. All right. Tell us about your involvement with Ms. Pennings, sir.
So I was rapid response. From my note, it looks like I was called to bedside to assess a patient who was hypoxic or wasn't receiving enough oxygen.
Okay. Thank you.
When I arrived, the patient was on a large amount of oxygen. They ordered ABG, or arterial blood gas,
You're good. Go ahead.
and a chest x-ray to assess the patient. The chest x-ray showed interstitial infiltrate, which could mean pneumonia
Okay.
or some sort of respiratory issue
Okay.
going on with the patient. And then the arterial blood gas, as listed, from my recollection of reading ABGs, it's been a while, but
Okay.
it appears that she wasn't receiving enough oxygen and she wasn't breathing out enough CO2 to make her acidotic.
All right. And at this point, you indicate you're going to continue to monitor these symptoms?
BiPAP was placed.
What's BiPAP?
Which is essentially oxygen with pressure behind it, so it would
Okay.
help open the airway and deliver a higher concentration of oxygen.
Okay.
It's a step in between intubation.
Okay. And then I'm going to direct your attention to the next page. Again, is that your name?
Yes, ma'am.
What date is this involvement with Ms. Pennings?
The 19th.
So the very next day. What was your involvement with her at this point?
Looks like I was called back to bedside to assess. The same patient, still struggling with the oxygenation, even with the BiPAP that was placed. Again, we did another ABG, which did not improve from placing the BiPAP. And then at that point, I was in contact with the ICU charge nurse physician and decided to transfer to the unit.
Okay. And I notice it is the step-down ICU?
Yes.
So at this point, she's going into the ICU unit.
So you could go into the step-down ICU if potentially there were not enough beds in the main ICU.
Okay.
It could have been for that instance because there was no beds left.
Okay.
But it was, per my note, the step-down ICU.
Okay. Mr. Rudman, another patient you were involved with was Beverly Schertzinger. So I'm going to show you what's been marked for identification as State's Exhibit 3C. And can you identify the patient for us?
Beverly Schertzinger,
And her admission date
10/2/2017,
and her discharge date, sir.
10/9/2017.
And I'm going to direct your attention to the middle of the page here. Is that your name?
Yes, ma'am.
And what date was your involvement with Ms. Schertzinger?
10/10/2017.
And tell us about this involvement with Ms. Schertzinger.
So again, I was in my rapid response role. I was called by the standard floor to assess the patient who was hypotensive or low blood pressure.
Okay.
The vital signs when I arrived, blood pressure, obviously 84/47, which is low. She had had a liver biopsy prior to my arrival, and she presented with back pain and a rigid abdomen. They did a stat CT of the abdomen, which is an x-ray essentially, just a more in-depth x-ray. And it showed a small hemoperitoneum, which could be indicative of blood in the abdomen.
Okay. Go ahead.
So Dr. Mangan, who was the physician on the normal floor on that given night, they ordered a CBC, which essentially just looked at what her blood levels, her hemoglobin levels were, and then also placed a catheter to assess her urine output.
Okay.
Looks like her blood pressure dropped. A 1 liter bolus of saline, which is essentially fluid just to bring the blood pressure up, was given at that time. And the hemoglobin, which is a count of your red blood cells, were decreased, which suggested potentially a bleed from the liver biopsy.
All right. What else did you do?
Levofed was initiated because of the low blood pressure, 64/38, and anytime Levofed is initiated on the floor, it has to be the patient has to be transferred to the ICU for monitoring. Because
why is that?
The floor nursing, they're not trained or able to keep a patient with Levofed on the standard nursing floors.
Okay. So what happened next?
It looks like we increased the Levofed as much as we could. No improvement. Patient was intubated at the bedside on the standard floor. And at that time, a code blue was called because the patient lost her heart rate, her pulse. We did 2 rounds of CPR and then transferred her to the ICU. At that time, the family decided to withdraw care.
Do you remember this patient at all, sir?
I do not.
So this is all from the medical records?
Correct.
So do you remember whether or not you were at the bedside at the time the family decided to withdraw care?
I'm not sure.
Okay. And in this note, does it note whether you were involved in the administration of any medication for her at the time they withdrew care?
Not in the note, no.
And if you had been involved, would there have been a note regarding that?
Usually, yes.
Okay. All right, so the last patient I want to talk to you about is Ryan Hayes. And this is State's Exhibit 2E. Can you identify the patient for us, sir?
Ryan Hayes.
And his admission date?
4/2/2017.
And his discharge date?
4/4/2017.
And Mr. Rudman, fair to say you're very familiar with this patient?
Yes.
Why is that, sir?
This was the patient where I administer medications and was the subject of the nursing board hearing.
Okay. So let's talk about,
No, ongoing, good.
I'm sorry?
Just my ongoing.
Okay.
all right, I want to direct your attention to April 3rd of 2017, which is our medication order we're going to talk about. What was your role in the hospital on this date?
Rapid response.
So what happened that called you to the bedside at this point?
In this instance, the ICU called me
Okay.
because they were very busy, as they were most nights. The patient, or the nurse in charge of Mr. Hayes, was getting an admission from the emergency department for a full arrest.
And do you recall who that nurse was?
Tyler Springer.
Okay, so what happened when you got up there as rapid response nurse?
I met Dr. Husel and Tyler Springer at the Pyxis, where I received a brief report about the patient and the orders given for the palliative withdrawal.
Okay.
And the explanation that they had another patient to attend to.
Okay, and what were the orders you were given for the palliative withdrawal medication?
1,000 of fentanyl,
Okay.
10 of Versed, and 10 of Dilaudid.
Okay, and did you withdraw those from the Pyxis machine, sir?
I withdrew part of the order.
Okay.
Tyler Springer had initially began withdrawing when I took over assistance.
Okay, so at the top, this would be the order for the 1,000 micrograms of fentanyl,
Correct.
and it says IV push. What does that mean to you, sir?
Given intravenously, IV as a push rather than a slow drip through a bag of medication.
Do you recall how many vials of fentanyl you would have had to withdraw to meet the 1,000 micrograms?
I don't.
Okay. And then I'm going to direct your attention to the next order on the page. What is this, sir?
Hydromorphone or Dilaudid.
Okay, and how much of this were you to withdraw?
10 milligrams.
And on the next page, what is this?
Midazolam or Versed.
Okay, and how much did you withdraw of this?
10 milligrams.
And approximately what time did all of this happen on April 3rd, 2017?
It looks like around 22:53 per the records.
So once you withdrew this medication, Mr. Rudman, what did you do with it from there?
After I withdrew the medication, I met family at bedside and withdrew the medications from the vials, medicated Mr. Hayes with the medications that were ordered, and then extubated the patient per the orders and the family's wishes.
How many syringes would you have had to have used, sir, if you remember?
I don't remember.
Okay. Would all have gone into one syringe, or would you have done them separately?
Objection, said he doesn't remember.
I will permit it.
I don't remember.
Okay.
Usually it would be separate.
Okay.
Objection, move to strike the anything after I don't remember.
I'll permit it to stand overruled.
And Mr. Rudman, you withdrew these upon the order of Dr. Husel?
Correct.
Did you, in fact, administer these medications to Ryan Hayes at that time?
Yes.
Now, you had just come to the floor. At any point, did you have the opportunity to check Mr. Hayes' medical records?
I did not.
Did you, prior to administering these medications, enter any type of pain score into the system?
I did.
Okay. And I'm going to direct your attention to the next page. Can you show us where you entered the pain score?
It was 4/3/2017 at 22:57.
And you entered a 10 at that time.
Correct.
At any point, did you review prior to that the last 2 days' worth of pain scores that showed 0?
I don't recall.
Okay. Do you recall what Mr. Hayes' injury was, why he was there in the ICU?
I received a report by Tyler Springer, the nurse, and Dr. Husel prior to administration of the medications that he was a 39-year-old male with polysubstance abuse history. He was found down by a family member in the bathroom after an undetermined amount of time. When EMS was called, they did multiple rounds of CPR, eventually brought him to Mount Carmel West, where he was resuscitated again in the emergency room, and then transferred to the ICU. So
That's the information you had.
anoxic brain injury related to a drug overdose was the information I had.
Why did you put the pain score of 10 in there, sir?
In hindsight, with the
Objection, Your
CPOT,
Honor.
Okay. The question is why, it's sustained. The question is why did you put the 10 down?
for the pain scale, we were taught as nurses that palliative extubations, the process of dying, was a very painful event. So we were putting pain scales as anticipatory pain for comfort care related to palliative extubations.
So this 10 is anticipatory.
Correct.
Now, the CPOT, is that the instrument you used in regards to this?
Correct.
Are you aware that that only goes up to a pain score of 8?
Yes, ma'am.
Okay. Then why the 10?
In haste, it was an error.
Okay.
I was going for the maximum pain level.
Other than anticipatory pain, did you see any other indication of pain in Ryan Hayes before you administered these medications?
I don't remember.
Okay. The fentanyl, what type of medication is that?
An opiate?
And the hydromorphone?
An opiate?
And the midazolam?
Sedative?
Now, when you pulled these medications from the Pyxis, did you await pharmacy approval?
I did not.
So you pulled these via an override?
Correct.
Why would you do that when typically you wait for pharmacy approval unless it's an emergency?
Really, any time I was called, it was of some urgency, as I was the only nurse as a rapid response at any given time. So if a code blue were to be called, that would be where I would have to go, and it could be across the hospital at any given time. In this instance, the family had traveled all day and were at bedside because some loved ones were coming from out of town, and it was a palliative extubation that was planned during the day but was completed at night because of that family dynamic.
So in your eyes, this was an emergency?
Yes.
Your Honor, if I can have a moment?
Yes.
Mr. Rudman, do you see Dr. Husel in the courtroom here today?
Yes.
Could you please point to him and
Stipulate to identification.
Okay.
Okay. Again, they're agreeing that he would identify Mr. Husel, so.
Thank you, Mr. Rudman. I have no further questions, Your Honor.
Ms. Menashe?
Thank you, Your Honor. One moment. Oh, are you exhibit? Oh, I'm sorry. Do you need photos? No. Sure, I'll have the photos. Good morning.
Morning.
Diane Menashe on behalf of Dr. Husel.
Nice to meet you.
Nice to meet you. Just want to, got some follow-up questions, as you might imagine. I'll start from where you ended, if we could. Fair to say that when you were called as a rapid response nurse to the ICU with respect to Mr. Hayes, you understood that it was a palliative extubation.
Yes.
And you just testified to that it is your understanding that the decision had been made by Mr. Hayes' family to palliatively extubate him during the daytime shift.
Yes.
And that there was a pause or a gap in time between the decision and the night shift because family members or a family member was coming from out of state.
That's correct.
When you were at the Pyxis machine with Mr. Springer and Dr. Husel, you were then, as you testified to, provided with some information with respect to what medication had been ordered for the extubation. Is that correct?
Yes.
Fair to say that your intent at the time in administering the 1,000 of fentanyl and the 10 of Versed and the 10 of Dilaudid was to provide comfort to the patient?
Yes.
I want to go back to the Mars with respect to Mr. Hayes, if we could. In preparation for your testimony today, did you have an opportunity to review the entire medical administration record for Mr. Hayes?
Yes.
And I just wanted to ask you some follow-up, because while you testified that in hindsight it was an error to write the 10, you're aware, are you not, that after the 1,000 and the 10 were administered by you, that a different nurse actually indicated that that medication had not relieved the pain of Mr. Hayes?
After reviewing, yes. I was not present during that administration.
But now, and I'm asking this because of your answer on direct, you are now aware, are you not, that a totally separate nurse, Nurse Springer, is that fair to say?
Yes.
Had indicated actually on the Mars that the 1,000 of fentanyl, the 10 of Versed, and the 10 of Dilaudid had not relieved Mr. Hayes' pain.
That's correct.
And that was actually indicated as a pain relieved no. Would you agree with me?
Yes.
And I'm just generally about Nurse Springer. I know you've been asked about this previously. Fair to say that that's a nurse that you trusted?
Yes. I actually went to school with him.
You went to school, and I think I remember also that you did orientation together. Is that fair?
We started at the same time.
And so someone that when you worked with him, you had no reason to doubt his credibility or the things that he might say or do?
No.
If I could, tell me with respect to, and I'm trying to just, showing you what's previously been marked as States Exhibit 2E. When you are entering in the pain scale, and you were shown this on direct, does this look familiar?
Correct.
10 is noted multiple times by you. Do you see that at 2257?
Yes.
Okay. And is 10, is that something that you manually entered?
Yes.
Fair to say that in your career as either a rapid response nurse or an ICU nurse, this isn't the only time that you've ever entered a 10?
Correct.
And just so we're clear, there's a little number 11 and a number 12 here. If you know, what do those indicate?
I'm not sure.
Okay. And you reviewed this document in advance of your testimony today?
Yes.
And would you agree with me that the entries from Nurse Springer are 19 minutes after the indication that you put as a 10? Would you agree with me on that?
Yes.
And tell the members of the jury, fair to say that like 15-minute checks are kind of standard operating procedure, is that right?
Yes, after pain medication administration.
After pain medication administration, then there's like 15-minute checks to see if the medication's working or if it's not.
Yes.
You had mentioned that Mr. Hayes had anoxic brain injury and was an overdose situation. Is that correct?
Yes.
And also, I just wanted to note one other thing, if we could, going back to this. I know you testified on direct that by entering a 10 into the system, you consider that like anticipatory pain, right?
Yes.
And would you agree with me that anticipatory means I'm doing something in advance of something else that might happen?
Yes.
Okay. And so I just want to make sure that we're clear here that the order date and time for the fentanyl was 2253. Is that correct?
Yes.
Okay. And your last updated, and it indicates 2253.
Yes.
And then if we can go to the pain charge, it's 2257 that you enter 10.
Yes.
You mentioned with respect to Mr. Hayes that you were called to ICU, and I wrote down because the ICU was very busy, as it was most nights. Let's talk about the night of when you were called for Mr. Hayes. ICU was busy that night. Tell me, you don't remember the number of beds in ICU, correct?
Correct.
But fair to say that sometimes, even during the night, that the ICU was so full that someone might first have to wait to get to the ICU and go to step down.
Yes.
And the night of Mr. Hayes being a busy night in the ICU, that is not unusual.
No.
And in addition to the nurses and charging nurses and the physician on the ICU, there was always the capability of someone at the ICU also calling a rapid response nurse, such as yourself, correct?
Yes.
There's kind of lights are on the ICU at night, is that fair to say?
Yeah.
Things are active.
Very busy.
I want to talk about, if we can, Beverly Schertzinger. Showing you what's been marked as State's Exhibit 3C. Fair to say that, absent your review of these medical records, you have no independent recollection of this patient, do you?
I do not.
And did you review her entire medical record in preparation for your testimony?
Not the entire record.
The testimony you gave with respect to Ms. Schertzinger, your involvement was prior to her getting to ICU, or was it both before and after she got to ICU?
Before and after.
Okay, so I want to talk to you about showing you what's been marked as Joint Exhibit 3, page 817. First of all, just generally, what does this sheet appear to you if you recognize this type of document?
These would be the code notes.
And who fills out the code notes?
A nurse, usually.
Is this your signature right here?
Yes, ma'am.
And so before I asked you questions about it, I wanted to make sure that that's your signature. Can the jurors still see? Great. So does it appear that this code sheet relates to patient Schertzinger?
Yes.
I want to just go through it if we can together. The date is 8/9 of 17.
It looks like 10/9.
I'm sorry, 10/9 of 17.
Yes.
And the time of the code appears to be what?
21:56.
So, and obviously that's military time. Tell me what non-military time would be.
It's been a while. I believe that was 9:56.
And so we're talking night shift.
Yes.
And does it appear, based on the note over here, that as of this time of day, so at 9:56 at night, she is in the ICU?
Yes.
If you can, fair to say, Dr. Husel is the physician's signature down here on this code sheet.
Yes.
Talk me through at 21:56 what's happening on this code sheet.
At 21:56, looks like CPR was started. The patient was in PEA, or pulseless electrical activity. There was no pulse.
Okay, get a little volume.
1 milligram of epinephrine was administered. The patient was intubated and started on Levophed and vasopressin.
Okay, so let me walk you through this. This right here, the 1 milligram of epinephrine, that's to help someone live, right?
Correct.
And the same thing about them being intubated, right? That's a life-saving measure as well, is it not?
Correct.
And then it looks as if the levo, the vasopressors were increased. Is that a fair summary of what's over here?
Yes.
And then does it look like 2 minutes later, those life-saving measures, her heart rate actually drops? Would you agree with me on that?
Yes.
And then we've got 2 minutes later after that, her heart rate is still at that 68.
Yes.
And so what, if any, life-saving measures are done under the guidance of Dr. Husel at that time?
An additional dose of epinephrine.
And then it's hard to read this, but we can, fair to assume this last number is later in time?
Yes.
And it looks like from that epinephrine dose that her heart rate increases?
That's correct.
And what's this note over here, if you can decipher that?
The heart rate was picked up via a Doppler, which was a machine that we used with weak pulses, weak heart rates during code situations, and then the blood pressure was taken on the left arm.
So, and do you have any independent recollection of this event?
No.
When there's a physician signature on a code, fair to assume the physician is in the room calling the code.
Yes.
Is that right? Tell me visually, or tell the jurors more importantly, how that works. Code blue is called. Who's in the room?
A lot of people. Usually the physician, Dr. Husel, any nurses, respiratory therapist, pharmacist. Usually the family members are escorted out at that time, and all hands on deck situation essentially.
An all hands on deck situation, because fair to say everyone in the room knows that that person might die right then.
Yes.
Chaotic?
Can be.
And this last note right here, when it goes, this patient's heart rate goes to a 74, Doppler reads it, and a blood pressure is indicated on her left arm. She lives.
Correct.
And this moment, right, where her life is saved, is approximately 2200 on 10/19/17. Would you agree with me?
Yes.
And I want to take you back, 10/9, sorry. Take you back to State's Exhibit 3C. Later that night is when she passes.
Correct.
How many codes, if you recall, and an estimate was good, did you participate in with Dr. Husel during your time at Mount Carmel West?
A lot. I couldn't put a number on it.
And just because I'm a lawyer, I'm going to ask for a number generally. More than 20, less than 20, more than 50?
I would guess more than 50.
So more than 50 times in your time as either a response nurse or as an ICU nurse, you were in a room with Dr. Husel when he is coding patients and trying to save their lives.
Yes.
And saving their lives.
Yes.
I want to talk about patient Melissa Pennings. You were shown State's Exhibit 14G. Just want to confirm that your involvement with Ms. Pennings was not in the ICU. Is that correct?
Correct.
Okay. And so, given that it wasn't in the ICU, it had nothing to do with Dr. Husel.
In these situations, I oftentimes called the ICU, Dr. Husel included, to essentially put them on his radar, ask for his assistance or guidance at that time, and facilitate the transfer to the ICU. I would be with him the whole way.
And this is why, on direct, Ms. Sawyer said that you're good, because I was going to ask you a question about, did you sometimes call Dr. Husel before a patient even got to ICU and say, hey,
Is there a question here?
yes, hey, you called him at times, did you not, and say, patient's on the way, have a heads up for this patient?
Yes.
And there were times even before a patient got to the ICU where you might call him for advice or bounce a question off him as well. Is that correct?
Yes.
And when you would make those calls to him, fair to say that he was approachable,
Yes.
accessible,
Yes.
willing to take the time to listen to the question and answer it?
Yes.
You were asked about the shifts, 7 p.m. to 7 a.m. I know was your shift. As a matter of practice, when the shifts would change between the nurses, was there or wasn't there like a huddle where the night shift would talk to the day shift nurses and ensure there isn't a gap in care?
Are you talking general ICU?
Yes, general ICU.
Yes. We would get bedside report from the day shift nurse that cared for the patients that we were assigned that night.
And purpose, based on your experience, is so that despite the shift change happening, the patients continue to get constant care.
Correct.
And that was a part of those huddles or those, the exchange of information was a regular practice within the ICU, was it
Yes.
not? I know you were asked a lot of questions about what you consider to be an emergency. I noted that you indicated that as a rapid response nurse, kind of by definition, anytime you were called, it was an emergency.
Yes.
And part of your title as a rapid response nurse is rapid,
Yes.
right? So you come quickly.
Yes.
Overrides were a common thing within Mount Carmel West during your time there?
Yes.
I noted, in fact, that on your direct you indicated that they were very common.
Yes.
Speaking of overrides, though, I know that you've been interviewed by police in this case, correct?
Yes.
And I know at one point that you had a deposition. Isn't it true that you were asked the question about your practice or you using overrides in relation to Dr. Husel? Do you remember being asked about that?
Not exactly, but
Okay, let me ask this. Fair to say that any override that you ever entered into the system was not at the direction of Dr. Husel?
no.
That is fair to say?
Yes, that is fair to say. Sorry.
That's okay. I just want to make sure we're clear. As a nurse, nurse, rapid response or ICU, fair to say you rely on your school,
Yes.
other trained nurses that you're working with, your peers,
Yes.
your own personal experience,
Yes.
and the physicians that surround you.
Yes.
All of those things come into play when you're doing your job on a daily basis.
Yes. Oh, sorry.
There was just a question about the step-down ICU, and just to be clear, Dr. Husel did not work in the step-down ICU, is that correct?
Yes, he would.
Oh, he would work in the step-down?
Yes.
And what years was that, if you recall?
I don't remember the exact year it was initiated, but I would say that at least through 2017 to 2019, or 2018, I guess.
And the step-down at that time was on a different floor or same floor?
Different floor.
Got some questions, some general questions, if I can. Let's talk about patient-specific. And those are just two words used together. Fair to say that in your experience and training, you believe that every patient is different.
Yes.
And when you, as a nurse, are treating and caring for a patient, it's individualized.
Yes.
You have to look at a number of different factors when determining what is appropriate as to how to treat a patient.
Yes.
And, I'm sorry, I just have to speak.
Yes. Sorry.
And the same is true, how many palliative extubations have you been involved in your career?
It would be an estimate. I would guess over 50.
And palliative extubations at Mount Carmel West could occur during the day shift and also during the night shift. Is that true?
Yes.
And of the 50 approximate palliative extubations that you've been a part of, fair to say that those are also patient-specific in terms of what's appropriate with respect to dosages?
Yes.
And you've worked, obviously, in those situations with a number of doctors, ICU physicians.
Yes.
And wouldn't you agree with me that even physicians do things differently?
Yes.
In fact, I know that Dr. Husel was on the night shift with Dr. Hagris, and they did things differently, did they not?
Yes.
But at the time, you both found them both to be smart doctors.
Yes.
In these situations where you've been part of a palliative extubation, there's a discussion with the family.
Yes.
And at Mount Carmel West, isn't it true that oftentimes there's a chaplain that comes and is involved in the discussion?
Yes.
Going specifically back to the Ryan Hayes matter, there wasn't a family discussion with Dr. Husel with respect to Mr. Hayes because that decision had already been made on the day shift.
I believe so.
When you administered the order for Mr. Hayes, where was Dr. Husel?
He was assisting with Tyler Springer in the fresh admit from the emergency department.
Because there was another patient at that very moment that was in critical condition, was there not?
Yes.
And that's kind of part of this busy nature of the ICU, right? It could be one patient that you could lose and another patient you could be losing simultaneously.
Yes.
I forgot to ask you something about Beverly, if I could just go back to Ms. Schertzinger. One moment. Because I remember the questioning about there's the front side and the back side of ICU. Do you remember those questions?
Yes.
Just give me a second. testimony. Yes, that's where I'm going. One moment, sorry. Just going through my notes. You were asked these palliative extubations, 50 or so. Fair to say that sometimes they're not pretty.
Yes.
And I just need you to speak up a little bit. And in your experience in these palliative extubations, that patients can experience pain.
Yes.
And have you ever heard of the expression "a bad death"?
Objection, Your Honor.
I'll permit the answer. You ever heard that expression?
Yes.
And have you ever, in your experience as either a rapid response or an ICU nurse, seen a bad death?
Yes.
What does that describe that?
As in his experience.
In your experience as a nurse?
Any time where the patient that has been withdrawn on is experiencing discomfort, agonal breathing, air hunger, physical distress, is what I characterize as a bad death.
And in your experience as a nurse, throughout those years, there are a number of times when the family members are in the room. Is
Yes.
that right? And seeing that, the air hunger, right? And air hunger is gasping for air. That kind of
Objection, Your Honor.
noise.
Sustained. Let's ask the question, please.
Gasping for noise. Is that
Yes.
fair?
Okay. It was sustained. You got half of a question now. Ask the new question.
Okay. And obviously, the family members are in the room should they choose to be during the extubation and after the patient is extubated.
Yes.
And when you've seen those bad deaths, and I'm not going to ask you to, of course, say any patient names, but do they stay with you?
Yes.
Where's the picture? No. One moment. I want to just talk to you about the nursing station. And then I will be done. One moment, please. Of course, it has to be the last photo. Showing you what's been marked as States Exhibit 15Z. This is a nursing station right here? Sorry.
Yes. Oftentimes the pharmacist would use that computer as well.
Thank you. And does it appear, I'll zoom in a little bit, that there's actually two monitors there?
Yes.
Based on your experience and time at Mount Carmel West, would sometimes a nurse and or pharmacist sit there just if they weren't actively engaged in something else?
Yes.
And what does this room number look like here?
Room 9?
And this area right here, is this a traffic area? People would walk in and out from there?
Yes.
Just want to go back to, if we could, that code sheet I showed you with respect to patient Schertzinger. Joint Exhibit 3, page 118. The room number appears to be what for that patient?
Room 9?
So it's right there, right next to the nurse's station.
Yes.
And with respect to the nurse's station, if you recall, based on your experience as a nurse at Mount Carmel West, that if a patient is being palliative extubated in room 9, that I, as a nurse, could give the family some privacy and sit right here and monitor.
Yes.
And is that, in your experience, a practice that was done, that a nurse might leave and then monitor the situation from a terminal?
Yes, every room had a curtain that could be closed.
And was that a practice that you did?
Yes.
You did that. And tell us, when you're here during an extubation, what information you can see on the monitors as to what's going on in the room.
We still have access to heart rate, sometimes blood pressure from the nurse's station. At that time, the monitors are usually in the rooms, are usually put on standby so that the family don't incessantly watch it.
And when they're put on standby, fair to say that the noise is also turned down so it doesn't distract the family?
Correct.
But you have full capability during your experience to monitor the situation from a terminal.
Yes.
And that would be something that you would have done during a situation like that, is it not?
Yes.
One moment, Your Honor. Nothing further. Thank you.
Okay. I assume you got more than 10 minutes?
No, I don't think I do, Your Honor.
Okay. Then we'll sally forth.
Sorry, I'll reorganize them.
That's all right. I'll give you a hard time later. Mr. Rudman, where did you learn, or who taught you that agonal breathing is painful?
Nurses, charge nurses, physicians.
Okay. Are you aware of literature that says it's not painful?
I have seen that literature.
Okay. The code sheet, Diane, can I borrow that back from you? And I'm going to show you, this is Joint Exhibit 3, page 817. When there's a code going on, is this when you're using the code cart, the emergency cart?
Yes.
And epinephrine, the levophed, those would all be available on there.
Yes.
Would you ever use fentanyl in a code situation?
No.
Why?
We're trying to resuscitate a patient. That's not a medication used to resuscitate a patient.
What about midazolam?
No.
What about Versed?
No.
Why not those two?
Same reason.
Okay. And in regard specifically to Ms. Schertzinger, and I'm going to point your direct attention to 3C again, and your involvement. So in this note, you talk about that code that we just looked at. Is that accurate?
Yes.
At that time, well, first off, are you familiar with what a DNRCC and a DNRCCA is?
Yes.
What's a DNRCCA?
A DNRCCA is a code status that indicates that all life-saving measures will be applied up into cardiac arrest.
Okay. And a DNRCC?
Your Honor, I think it's beyond the scope.
Well, it goes to the medical records, I'll permit it.
DNRCC is?
Comfort care.
Okay. So in this situation, as you're administering CPR, are either of those statuses in effect for Ms. Schertzinger?
From my note, I'm unsure. I would assume it would be arrest.
So because you're doing CPR, at the most it would be a DNRCCA?
Objection, Your Honor, leading.
It would be full code, excuse me.
Okay. So
Your Honor.
Okay.
Okay.
Overruled.
So it would be full code, which means you go ahead and do the CPR. At the time, and at that point, you wouldn't be looking at fentanyl, midazolam, or Versed.
No.
What about when the family decides to withdraw care? Would that be when one of those statuses go into effect?
Yes.
So at that point, would life-saving measures be used?
Life-saving, no.
Thank you. No further questions, Your Honor.
Okay, you may step down. Let's take our break, ladies and gentlemen. Just hang tight for a second. I'm going to get them in their break. I'll see you guys in 15 minutes.
All right.
Let's say 22. I'll give you 18 minutes. That way there's no flux to the bathroom. Very admonitions. I'll see you guys at 22.
Oh, and these are the ones in house.
back through that, of course. Mr.
Okay,
President.
Ms., go ahead. So let her get up. Ms. Sawyer, anything for the record?
No, Your Honor.
Ms. Menashe?
Thank
Ms.
you.
Menashe, anything for the record?
No.
Okay. We're on break.